Okay, are we back? Can you hear me?
Yes, ma'am.
And can you see Chapter 1, the anatomy of the periodontal structures, the healthy state?
Yep.
Which, if today we're talking the healthy state, guess what next week's going to be? The anatomy of the periodontal structures, the unhealthy state. Shades of things to come. Michaela, I texted you, I DM'd you on the chat. So take a look at that.
Okay, thank you.
I gave her a job. She said, about the quiz dates. This is what happens to adjust the quiz dates. Michaela, I threw you under the bus. You're going to tell me what I need to put down, okay?
All right, got it.
Real quick, Misty, totally unrelated, but have you had a chance to look at Navigate? No one's been able to submit Navigate yet.
Seriously?
It doesn't seem like there's an option to submit it on Canvas for 142.
Oh, you're taking the quizzes, you just can't submit them.
Yes.
So I need Navigate link. Thank you. Okay. Phew. This is the first time first year we're using Navigate. So, and the first year we're using Canvas. So this old horse is having to make a lot of adjustments, and I do apologize. And I love you guys for being so flexible. But yes, I've got that on a sticky note.
Thank you.
Because if it's not written on a sticky note, it's not going to get done. Before we get started with this, I do want to make a plug. I said I'd have a sign-up sheet outside my office, but that's not going to work as well. If you are interested in taking the course, it's a live webinar next Wednesday. It is sponsored by Waterpick, and it's going to be on perio. It's going to be on the AAP classifications, which you will be doing on each of your patients. So if you would like to attend, it's free to students. Slip me an email that you'd like to attend, because I'm the coordinator of it for the association, but I have to get your emails to somebody. And then the following month in February, we have the most fabulous speaker. He is a microbiology nerd who is going to be talking about irrigation and what do you actually do with the bacteria that's underneath the gum tissue for the patient. So that's going to be really good as well. So to expand your knowledge, I'd recommend you participating in something like that if you'd like. Okay, so let's go into the introduction of what the chapter is, and this is the anatomy, and you've had all of this before. So we've got the periodontium, and the periodontium is divided into the gingiva, your PDLs, cementum, and alveolar bone. That's the periodontium. But the attachment apparatus, look at this, it's the PDL again, the cementum again, as well as the alveolar and supporting bones. So these double dip. This is from the book. Okay, you should know all of these landmarks. You have your gingiva here, the collar gingiva. You've got your periodontal ligaments attaching to the cementum, your alveolar bone, the alveolar process itself, and your PDLs where your attachment fibers are. Different mucosas, masticatory, lining, and specialized mucosa. You do need to know the difference. Masticatory mucosa is the gingiva and hard palate. Lining mucosa, alveolar mucosa, and the floor of the mouth, and then the specialized mucosa is the dorsum of the tongue. So, masticatory, what's the difference between the masticatory and lining mucosa?
Masticatory is more hard, like hardened.
Keratinized.
Keratinized, thank you. What makes it harder? It's keratinized because it has to withstand the forces of eating, versus the lining mucosa is non-keratinized. Also, the gingiva and the hard palate is firmly attached, and the lining mucosa is not. And then we've got the dorsum of the tongue. So we've got the parts of gingiva. We've got the free gingiva, interdental gingiva, and the attached gingiva. The free gingival margin surrounds the neck of the tooth. It's coronal. It's the most coronal aspect of the gingiva. Apically to that, you've got your free gingival groove. Now that free gingival groove only is seen in about 30 to 40% of the population. So when you get back into mouths, take a look at your partner. Can you see the free gingival groove? Do they have stippling? Because not everybody has stippling as well. Look at these landmarks. Smooth, firm surface. It's the entry into the gingival crevice, which is the sulcus. And if it's a non-healthy crevice, what is it called?
Pocket, a
A
periodontal
pocket. It can be a gingival pocket or a gingival sulcus. It's a gingival pocket, meaning you don't have any apical migration of that junctional epithelium, but it's diseased. After eruption is completed, that free gingival margin is located 1.5 to 2 millimeters coronal to the CEJ. So we're used to not seeing the CEJ. We shouldn't be seeing it. If we see the CEJ, there's recession that we have to mark down. That's why we also allow that healthy gingival crevice to be 2 to 3 millimeters. Sometimes it can be a little bit more, depending on where that gingival margin is and if there's any disease present. But that gingival crevice underneath the gum tissue, it's the space between the tooth and the gingiva. So the top portion of that, the coronal portion, is the gingival margin. When you're inside the crevice, one side of it, lateral side, is the epithelium, the tissue, and the other side is the tooth. Then down at the bottom, the apical portion, you have the coronal portion of that junctional epithelial. The coronal portion, it's only a few cell layers thick, up to 15, okay, but you've got coronal, junctional epithelium, and the apical portion of the junctional epithelium, because everything's got a top and a bottom. You have the gingival crevicular fluid. It's generally not a lot of fluid. You're not oozing all the time, all right? But it's a very slow rate. The fluid, it comes from the blood vessels. It resembles serum. And the flow is dependent on inflammation. So if there's no inflammation, it's very low and it increases with inflammation. The gingival crevicular fluid increases with inflammation. That's your takeaway. Those are usually board question items. The attached gingiva, again, the top portion is you're looking at the free gingival groove or the base of the pocket or sulcus. The bottom portion of the attached gingiva, the apical portion, is that mucojunctional junction. The width varies. It's not movable. The attached gingiva is not movable. It's firmly attached to the underlying bone, the cementum, okay, by the connective tissue fibers. So where is the attached gingiva the thickest as far as the width of the attachment? Will Peck. Does anybody, I don't know who a Will Peck is. I'm not going to admit him. Where is it the widest when you're taking your measurements from the gingival margin to the mucogingival line?
Like interdental?
Well, could be.
Where it's attached to bone.
Okay, now where is it? Anterior, posterior?
posterior.
All right, this is a review. It's thickest usually on the maxillary anterior teeth. Okay, think about, number 8 and 9. you could have like 8-10 millimeters of attachment. Where is it thinnest? It would be thinnest at the mandibular premolar area where the frenum attachment is. So those are, again, questions that we want you to know. It's thickest on the maxillary anterior, thinnest mandibular premolar area with the frenum attachment. It's also usually very thick on the mandibular posterior linguals. So these are the generalizations. So when we're reviewing your periodontal assessment that you have on your patients, we're expecting to see these certain numbers on certain areas of the mouth. And if we're not, then we're taking a closer look. So the thickness does matter because that's letting us know how much attachment you have. That attached gingiva contains pigment. It's oftentimes stippled, that orange peel effect. And you're measuring that total width of the gingiva, which is the free gingiva to the attached gingiva. You're measuring that. And then remember, for the CAL, you're subtracting your probing depth. And that is how much attachment is actually on the tooth.
Christy, I have a question. Did you also say, going back to the previous slide, that it's also very thick at posterior mandibular linguals?
Yes.
Is that what you said?
Yes.
Okay.
Also,
That's hard to see because you got the tongue in there and you've got lighting issues, and it's very hard to see. But you can have 8 millimeters of attached gingiva around those molars. And then around the premolars, it's usually about 4 millimeters, and around the anterior linguals, it's about 3 millimeters. You know, these are the generalizations that you're going to get to know when you do it over and over and over again.
Steve? Ella's in the waiting room. I think that was the Will that you saw. Ella.
Oh. Well, let me allow Will Peck in. Is this Will Peck? Thank you. Okay. Is Ella in now?
Yes,
Thank you.
thank you.
I apologize. I didn't recognize the name. And I can't imagine anybody wanting to Zoom bomb a perio class.
Sorry, this is my husband's name. Somehow, I don't know, it was
That's
loaded.
okay. Okay, that's fine. Now I'll know. Okay, so the attached gingiva. Okay, we're still discussing the parts. Free gingiva plus attached gingiva is the total width of the gingiva. That is what you're measuring with your periodontal probe, and then you're subtracting your probe reading or adding your recession to get your CAL. And the CAL is something that you are going to be doing in your head and writing down or entering in. The computer programs do the CAL automatically for you. We have disabled it because we want this to be knee-jerk reaction, so you can just go and do it. Because on your boards, they are going to be asking you to determine what the CAL is. And we want this to be so second nature that you don't need to think about it. But let's take a look at this, this picture here. It's supposed to be of health, okay, varying amounts. Look at this, around 8 and 9. Very, you measure here to here, very thick. Then it comes down and it lessens around the posterior. For the posterior on the mandible, maybe 3-4 millimeters here, it gets a little bit thicker, and then it gets thin again. So there are varying amounts that you will be measuring. So what we recommend for students to do is to take and just measure, do one measure, okay, in the center of the tooth. Okay, measure, 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 measure. And then what the computer's going to want, so if this is 6, you're going to put 6 here, and then your partner's going to put 666, 666, 444. But you don't need to measure each one unless it is weird. It could be 223, you know, if it's really oddly shaped. But you will have a partner to help enter this information in to the computer to allow the periodontal assessment to go a little bit faster. It's the first year we're doing this. Physiologic pigmentation. You need to describe the gingiva. Is it pale pink, coral pink, red, magenta, purplish? Physiologic pigmentation, generalized or localized. This physiologic pigmentation is just in the posterior, a little bit in the anterior, right? The nice thing when you have physiologic pigmentation is look how that demarcation line just sticks out, right? So it's very prominent. Surface stippling. Not everybody has it, but it is a sign of health, that orange peel effect. The interdental papilla or interdental gingiva. It's the extension of the free gingiva. It's not attached. It's pyramidal. Okay, it looks like a pyramid or a triangle in the anterior area because of the shape of the caul and the interdental area, and it flattens out in the posterior. It's non-keratinized, less pronounced in the posterior than it is in the anterior teeth, and that area is very susceptible to disease, the interdental papilla, because of the caul. Very difficult to clean. You've got also concavities in the tooth structure and the root structure. Flossing doesn't get concavities. So it's very susceptible, and that's where disease usually starts, is in the caul. So again, we're measuring, we're taking measurements, we are determining what type of embrasure space the patient has, type 1, 2, or 3. And as you're going to learn, if the patient has anything other than a type 1 embrasure space, now what is a type 1 embrasure space? It fills that embrasure space. A type 1 has a type 1 has the papilla filling the embrasure space. A type 2 does not fill the embrasure space. You've got a little bit of air. And then a type 3 is pretty blunted. So a type 1 embrasure space can handle floss, but if you've got a type 2 or 3 embrasure space where this portion is open, the patient needs something else besides floss, either a tufted floss or a little go-between that you're going to learn about, or a proxibrush, or something else to get that concavity. So we've got that junctional epithelium, apical to that junctional epithelium, okay? Your border is that mucogingival junction. You have alveolar mucosa, which is not attached. It's movable. There's no stippling. It's thinner, so it's also redder because you can see the underlying blood vessels. It's very vascular. So those are the areas that get the aphthous ulcers or the canker sores. You have your specialized mucosa, which is the tongue. The mucosa on the dorsum of the tongue contains the papilla of the filiform, the fungiform, the circumvallate, and what's not listed here. Filiform, fungiform, circumvallate. What's on the sides of the tongue?
Foliated.
Yes. Okay, so this is not, the book doesn't emphasize this, but you have to know that where those foliate papillas are. All right, so the filiform are slender and most abundant. They do not have taste buds. The fungiform are those flat, typically a little more they're more keratinized. They could be dark pink to red to brown to sometimes black, depending on the pigmentation. Fungiform, the apex or tip of the tongue, okay, the tip third, and the sides. You've got your circumvallate, which contain most of the taste buds, okay? Circular in the shape of a row. The cell layers, oh, not again. You need to know, my friends, you need to know both the basal layer and the stratum layer. You have to know both terms because we don't know what board questions are going to be on. There's always board questions, but we don't know what they're going to label them as, okay, or want you to know them as. So the basal layer, stratum, germino, okay, now look at this German, okay, the germ is where things start and originate, your tooth germ. So that's how I remembered the basal layer. It starts there. Then you've got your stratum spinosum, which is your prickle or spinous cell layer. Then you've got your granular cell layer. So we're going from the base where the germ is to the surface. Granular is easy because it's got the granulosum in it. And then the keratinized cell layer, and it's got that corneum, that corn husk. It's hard. So the basal layer is the germ layer. Then you've got your spinosum layer or prickle cell. Then you've got your granular, and then your keratinized. Stratified squamous epithelium. Now you've had this in histology, haven't you? Is this a review?
It should
Yeah.
be.
It should be. I know. Well, you know, I was sitting in the board review with the second year students. I take a board review every year just to make sure that we are touching on what we're supposed to touch on. And selfishly, I'm making sure that my courses are. And they said the same thing. They didn't have any new information, but they knew they had what they had to go back and look up again. So they were very pleased. The second year students were very pleased with the education that they had, because I remember last year somebody raised their hand and asked what the DMFT was. Do you remember what the DMFT is?
Was this for
Indices, right?
Yes.
Yeah, decayed, missing, filled teeth. They had never heard of that. And that's one of the basic indices. And they didn't go over indices, not even in public health. It was like, oh my gosh. So feel good about your education. We put you through HELL, but it's worth it. Okay. Squamous cell epithelium. You've got your stratified squamous epithelium, your orthokeratinized, which is your skin and your masticatory mucosa. Then you've got your non-keratinized, your alveolar mucosa and sulcular and junctional epithelium. Okay, it makes sense if you think about it. Then there's something called parakeratinized, which is part of the stratified squamous. And that is when you've got a variation of keratinization. So the surface layer, when you're making slides, stains for keratin, but there are shrunken nuclei, and those nuclei are retained in many of the cells. So it's not a usual thing that you see for masticatory mucosa to be parakeratinized. It's usually fully keratinized. Just some trivia. Stratified squamous epithelium is avascular with no nerves. Connective tissue is vascular with nerves. This is important information. And a photomicrograph, okay, where you can see all the various parts. So, is this area of the gingiva keratinized or non-keratinized?
Non-keratinized.
Non-keratinized, okay. And what is this part called?
The call.
Crevice.
Well, this is the
Margin.
call here. Although the call is down here.
Oh,
This is the gingival crevice.
yeah.
That's
the
margin.
gingival margin. So the most coronal aspect is the free gingival margin. Then you've got the gingival crevice here, where one side is the tooth and the other side is tissue. The most apical portion is that junctional epithelium. You've got the coronal is the most top part of the junctional epithelium, and then the apical part of the junctional epithelium, a top and a bottom. And another picture. This is telling you where the basal cell is. The basal, if you look here, it's the base. What is the other name for basal or the base?
Is it the one that has germ in it?
The one that has germ in it. Yes, you don't even need to know the stratum, because these are not fill in the blank questions on your boards or on your tests. So know that base and stratum. Okay, and then you've got your prickle, or what was prickle or spinosum? Yes, and then you've got
Granulosum.
granulosum. The granulosum is in between, and what is that outer area?
Keratinized.
Corneum. It's corn. It's think about a corn husk or a corn on a foot. Hard, calloused, firm. You guys got it. Very good. Okay, so now we have to delve into even more. The outer epithelium. It's perikeratinized or keratinized. Okay, and there are different cells. I don't get into cells in perio as far as of the gingiva. This was what you had in histology, so I am counting on you to be able to review histology. But what is the function? Protection. Cell renewal dates. This is important, the cellular renewal dates. It's about every 10 days. The function is to protect the underlying structure and act as a mechanical barrier. So if you have an ulcer on your attached gingiva, how long will it take for it to typically heal all the way? 10 days. This is where we're getting our 10 to 14 days, 10 to 2 weeks, 10 days to 2 weeks. Sulcular epithelium, again, it lines the sulcus. It's very thin, and because it's thin, it's more susceptible to infection. It has epithelial ridges or redipegs, and what do they create, those redipegs?
Don't they increase like surface area because they're like hills and valleys?
True, and yes, it does. And it also, doesn't that give that stippled effect? Question mark or yes, I know, it sounds familiar.
Yes.
Yeah, I mean, do it with gusto, guys. Do it with gusto, even if it's wrong. Be confident. Okay, so the sulcular epithelium, the top part is coronal. That's the crust of the gingival margin. The apical part is the junctional epithelium. So that junctional epithelium is very thin. It's non-keratinized. It provides contact between the gingiva and the tooth. They have wide intercellular spaces. Okay, wide intercellular spaces. Remember those desmosomes and hemidesmosomes? That's where this comes into play. And then the gingival connective tissue is underlying that junctional epithelium. So the big thing is that it is thin and it has wide intercellular spaces, so it's very susceptible to disease. It has neutrophils that are present in small numbers. Then you've got your hemidesmosomes and your basal lamina. Those two together is your epithelial attachment. Hemidesmosome is half of a desmosome, and those desmosomes relate to how widely spaced those cells are. But look at the cellular turnover here. You got to know this. Junctional epithelium, 1 to 6 days. Gingiva, 10 to 12 days. And the palate, tongue, and cheek is 5 to 6 days. So there's a pretty rapid cellular turnover. Look at that junctional epithelium, 1 to 6 days. Wow. So if you've got a canker sore or something else, or you bite your tongue, it's going to, this will tell you about how long you can tell the patient it's going to take to heal. Gum tissues heal very rapidly. It's amazing when you do a debridement or a debridement on a patient and you do 2 quadrants and they come back 3 days later for another 2 quadrants of debridement or scaling and root planing, whatever the terminology is you're using, you can see such a dramatic result in just a day or 2. It's amazing. Now, they're not healthy yet, but they're the signs of health and is increasing, and the signs of inflammation is decreasing because of this cellular turnover. Connective tissue of the tissues of the gingiva is the underline of the epithelium. So the boundary, it's the boundary between the connective tissue and the epithelium. So the connective tissue papilla extends into the epithelium. Remember, they've got those little fingers going into the connective tissue. And the connective tissue papilla is separated from each other by those red apex or the epithelial ridges. We've got our lamina propria. You've got your papillary layer and your reticular layer. Again, it's histology. I hate histology slides. I hated it in school, and it just looks like a blur to me. But you can see these fingers. This is a connective tissue papilla. Just like you have a papilla on the outside between your teeth, connective tissue papilla. And as Jonathan said, it increases the surface area. Okay, and it also helps create stippling. The lamina propria, you need to know this, collagen and ground substance. Look at the amount of collagen fibers, 60%, excuse me. Now, when we get into surgery and regeneration, we're going to be talking about type 1 and type 3 and type 2 and everything. So just know that there are different types of collagen. Most of them are type 1. Collagen fibers, 60% in the lamina propria. Ground substance, proteoglycans, okay, cells, vessels, and nerves. You have fibroblasts. Blasts, do they create or do they take away? They create. Okay, they synthesize collagen, fibroblasts synthesize collagen, as well as collagenase. So that's the enzyme that breaks down collagen. And there are actually tests that you can do chairside. to see if that patient has collagenase within that pocket, which is really cool. Okay. Fibroblasts synthesizes collagen as well as collagenase. The inflammatory and immune cells that are present. You've got mast cells, your PMNs, your macrophages, your lymphocytes, and plasma cells. So those were listed on a previous slide. Your mast cells release substances such as histamine in response to inflammation. We are going to get into histamine in detail. Did you learn about that in histology? If not, you're going to learn about it in pathology. Okay, there's a lot of crisscrossing of information. So Mrs. Heberly, I know she talks about it. I just don't know in what course, is going to be talking to you about histamine. Histamine is the body's response to inflammation. Think about your allergies.
It causes
Yes.
itching, right?
Yeah, you are sneezing, your eyes are running, you're having allergies. You take an antihistamine to control that inflammation that's going on. So histamine is a reaction to inflammation. Allergies isn't necessarily disease, right? But it's inflammation. Things are being irritated. Gum disease, periodontal disease is inflammation as well. And our body acts similarly. It doesn't know that, oh, this is gingivitis versus this is pollen. Okay, the body's response is the same. So we've got our PMNs, which are the first line of defense. They arrive first at the site of inflammation. They are phagocytes. They engulf the bacteria and ingest the bacteria. So what is the first line of defense for inflammation? It's your PMNs, your neutrophils. Those PMNs. There are certain diseases and conditions that we have in our body that decrease our body's ability to produce PMNs and neutrophils. So guess what? Those are the patients that aren't going to have that immediate response to fight impending infection. And we'll be getting into that too. Your diabetic patient, your smoker, there are a lot of other systemic situations that will inhibit PMN production. And that can be a bad thing because it's your first line of defense. So we've got phagocytosis. You've got your macrophages that engulf and ingest. You've got your lymphocytes and plasma cells that are involved in the immune response, which we are going to get into in more detail in both this and pathology. So we're dealing with an antigen or foreign material. I'm just going back to this one. My daughter got her second COVID vaccine, and she's getting the Pfizer. And the first vaccine, she just had a sore arm, and that was it. And the second one, she was fine with the sore arm the first day, but the second and third day after her injection, she was not feeling well. Skin was hurting, kind of like you had flu-like symptoms. And she's, this is the nerd in her, well, at least I know my body's making the antibodies because her body was responding to the vaccine. So that's one way to look at it. Gingival fibers. Gingival fibers, periodontal fibers, you know this. You're going to need to know it again. And then you're going to need to know it for your boards as well. Supracrestal fiber apparatus. Supra, is that above? Crest, the bone. Gingival connective tissue attachment, gingival fibers. So you can take the word apart and kind of figure out what you're talking about. But let's look at these supracrestal gingival fibers. You have your circular fibers go around the tooth. They help keep that gingiva close to the tooth because it's not attached. The dentogingival fibers, dentoperiosteal fibers, transeptal, tooth to tooth, and alveolo-gingival. So dento-gingival from the tooth to the gingiva, okay, dento, and or the tooth to the periosteum. What's the function of the lamina propria and the fibers? Holds the gingiva to the tooth and also connects it to the bone. So the junctional epithelium and the gingival fibers together create that dentino-gingival junction. Dento, excuse me, not dentino. I love this because I'm a chart person. This has everything you need to know. Everything you need to know. Circular, dento-gingival, dentoperiosteal, alveolo-gingival, transeptal. Okay, so know the chart. The collagen is densely packed. They're composed of heavy, tightly packed fibers. Their function is to resist tension. It's got to keep that gum tissue tightly bound around the tooth. You can also have loosely packed, and that's composed of thin, delicate collagen fibers, and they have no mechanical protective function. So you can see that that densely packed, it needs to be where the food and everything is going to be coming in contact with it, and that loosely packed is going to not have that protection. Then we've got these cell-to-cell intercellular bridges, okay, where the epithelial cells are held together by desmosomes. They can be very tight or they can be loose. They consist of two adjacent attachment plaques, okay, two pieces that are continuous with the innermost leaflet of the cell membrane. So with this, you've got a top portion and a bottom portion, even though it's the basal layer. The basal layer, you've got top and bottom, right? You've got your lamina lucida and lamina densa. And this is all on how things look underneath a microscope slide. So you've got your desmosomes here, okay? These are your intercellular layers, your desmosomes, all right? And then with that, you've got your lamina densa and your lamina lucida. Desmosomes are structures that cause adjacent keratinocytes to adhere tightly together. So you've got tight junctions, and those are specialized intercellular junctions that are formed by several proteins, and the two membranes form a sealing gasket. So those are the desmosomes. Then you've got these gap junctions, and those are the junctions between the membranes of the cells that allow communication between the adjacent cells. And where are those gap junctions that we talked about? A little bit wider. Those intercellular spaces are a little bit wider. Do you remember?
Is that where like the hemidesmosomes are?
Well, that's creating the space, but it's at that junctional epithelium. Okay, you've got that cell, a wider intercellular space at the junctional epithelium. A hemidesmosome is a half a desmosome, and that joins the epithelium at the basement membrane, the lamina lucida. I will let you know if I have test questions on that. I try and stay away from them because I have rarely seen board questions with that type of information in the perio section. So we've got our biological width that we've talked about in previous courses, and that's connective tissue attachment. It's about 1 millimeter or 1.07 millimeters plus the junctional attachment of 0.97. So we're just rounding up saying it's 2 millimeters. The importance is it's the distance, 2.04 millimeters is important when fabricating restorations because they must have an adequate biological width. So when the dentist is fabricating any type of restoration, they have to take that biological width into consideration. If not, if that margin of the crown or the margin of the filling or restoration is too close to the bone, the body is going to want to create that biological width. So there will be chronic inflammation and that bone will eventually dissolve to make that biological width. So on a radiograph, you want to measure the distance between the alveolar crest and the intended finish line of the restoration. That needs to be a minimum of 3 millimeters. This is something that the dentist does because it's impossible to perfectly restore a tooth to the precise coronal edge of the junctional epithelium. They allow a millimeter of wiggle room. So that's where the 3 millimeters comes in. The biological width is about 2 millimeters, but the width on a radiograph, you want to see about 3 millimeters. Okay, so this here from the dotted line to here is the biological width. So you can see here, if their restoration was impinging on this biological width, guess what? It's also impinging on that junctional epithelium. So you've got something jammed in here below that junctional epithelium. You're going to have chronic inflammation. Things are going to inflame until everything dissolves. Attachment apparatus. The pictograph. You saw this in oral anatomy. Periodontal ligament joins the cementum with the bony socket wall. It's made up of collagen, okay? Type 1 and type 3, mostly type 1. They have fibroblasts, cementoblasts, and osteoblasts. Fibroblasts we talk about, that makes collagen as well as collagenase. The periodontal ligament space is about 0.25 millimeters. It's narrowest at the mid-root area. The periodontal ligament contains Sharpie's fibers, and those are the fibers that are embedded directly into the cementum and the bone, are called Sharpie's fibers. You have alveolar crest fibers, horizontal, oblique, apical, and interradicular. Apical, alveolar crest, interradicular, between the roots. Horizontal, it's the shape of them, going straight across, oblique, going at an angle. What is the most prolific of the gingival fibers? Oblique fibers. And again, I need you to know the name of the fiber, what they attach to, what the function is. Okay, so we've got horizontal fibers opposes lateral forces. Oblique fibers, okay, they go angle. Absorbs occlusal forces. They are the most abundant of the fiber group. Apical fibers resist tipping. And it says it's one of the last fibers to form. Why would it be one of the last fibers to form? Why would apical fibers?
Root development.
Yeah, root development. There you go, because it's the last part of the root to actually form. So this is an important table for you. Functions of the periodontal ligament. Remember, it acts as a hammock. So you've got suspensory, supportive. It acts as a shock absorber. Again, supportive. It remodels, formative, resorptive, okay, because it's got fibroblasts and collagen and collagenase in them from the fibroblasts. The blood supply, okay, it's vascular and nutritive. Tactile, it's sensory. Proprioceptive, sensory. Not necessarily pain, but you can tell. You tap, tap, tap. Patient has a root canal. And they say, I have this dead tooth, but I can still feel it when I tap on it. They're feeling the periodontal ligaments. They're not feeling the tapping from the tooth. They're feeling the vibration from the tapping from the PDLs. Cementum is connective tissue. Collagen. Okay, look at the percentages. Cellular and acellular cementum. Nothing new. Cementum can be deposited continuously. It's avascular. It's not going to bleed. It's not going to hurt. Okay. Now the dentinal tubules can transmit sensation, but the cementum itself isn't going to hurt. There isn't any lymph vessels involved. It resorbs, but does not routinely remodel like regular bone. Avascular. Now we've seen this before too, and this is the percentages, and they reviewed this in the boards this last weekend as well, as far as where the CEJs fall, and it had this exact picture. Most of the time, the CEJ, this enamel, and the cementum overlap a little bit at the CEJ, 60 to 65%. About 30%, they meet. And in about 5 to 10%, there is a little bit of space. So this patient here is going to be much more sensitive than this patient over here. So when you have a patient where you can't even probe because they're going, oh, it hurts, the tooth hurts, it's not the gum, they might be one of these patients. We're rolling our eyes going, oh, you weenie, what, you know, tough it up. You know, we've got a job to do, but they might be one of these patients. And those are patients where topical anesthetic isn't going to really be effective for them because topical works on the gingiva. It doesn't work in the dentinal tubules. We've got our alveolar process. You've got the alveolar bone proper and the supporting bone. You've got your socket wall, which is part of that alveolar bone proper, the cribriform plate, the bundle bone, and the lamina dura, which is what you see radiographically. You have supporting bone, the compact cortical bone plates, and the cancellous trabecular bone. And what we look at radiographically when we are looking at their periostatus, we're looking to see if we can see that cortical bone. Can we see that white outline, that radio opaque outline? The lamina dura is, again, that radio opaque. It surrounds the tooth, and in healthy areas, you can see it on the sides of the tooth. This is their crustal bone, and on the side of the other tooth, they've got nice crustal bone. When this crustal bone is missing, it looks like this cotton candy, and it looks very fuzzy. How many millimeters from the CEJ should you be seeing this crustal bone? Because it's not supposed to be right at the CEJ.
Is it 2 to 3?
2 to 3 millimeters, exactly. So while this might look like they've got bone loss, all right, you want to always look to see where is that patient's CEJ, and then you go from there to the crustal bone to determine the amount of bone loss if there is any. So we always need radiographs when we're making a periodontal diagnosis. So that interdental septum or interproximal bone consists of the cribriform plate of the two adjacent teeth and some cancellous bone. It parallels adjacent to the CEJs. It's about 1.5 to 2 millimeters apical to the CEJ. Most of the books say it's about 2 millimeters. The contour follows, the contour of the bone follows the contour of the CEJ. So when we go back here, okay, the contour is very thin and pointy, versus if you had molars, it would be more flat. You'd have more of this crestal bone. So if you had a patient that had extreme crowding on these mandibular anterior teeth, they're not going to have that protective layer of this cortical bone because it's going to be even thinner because of the crowding. The alveolar crest is a parallel line connecting the CEJs. Again, this will allow you to determine whether it's vertical or horizontal bone loss by connecting CEJs. The shape of the alveolar bone crest is influenced by the width of the interdental space, the stage of eruption, the position of the teeth in the arch, as well as the shape of the CEJ.
Misty.
Yeah.
So if you were to correct crowding with like orthodontics or something, would you find that that the lamina dura would display on radiographs once the teeth have kind of stopped shifting and the bone is?
Yes.
Awesome. Thank you.
Yeah. Okay, you need to know, again, the difference between dehiscence, fenestration. We have this in oral anatomy. Fenestration, the loss of radicular bone, okay, the surface of the root, okay, but not including the margin of the bone. So the fenestration is the window. It still has the cortical bone, versus a dehiscence is the loss of radicular bone, including the gingival margin. So the fenestration is a window. This is the fenestration because it still has the bone here, versus a dehiscence. This was on the board review. Fenestration, window, dehiscence, it's missing the marginal bone. The physiology of the periodontium. You've got blood supply to the periodontium is provided by vessels of the periodontium and supraperiosteal arterioles. The interdental arterioles as well. So you've got all of those tiny little blood vessels. Changes with aging. The cementum increases in thickness throughout life. Everything changes with aging. The cells within the periodontal ligament decreases in number because we're not going to be as prolific as when they were younger. The number of elastic fibers increase. The space has to be taken up with something. Changes in the alveolar bone can occur, and the proximal surface contacts of the teeth wear down. The proximal surface, that contact area, wears down. Why would they wear down? Think about that microscopic, the teeth are in a hammock of our PDL. So every time we use our jaw and chew, we've got microscopic movement going on in that hammock, and that is wearing down our interproximal spots. So the attachment of the soft and hard tissues to the tooth surface contributes to the stability and health of the periodontium. The junctional epithelium is semi-permeable structure that it's involved in the movement of fluids, cells, substances from the lamina propria into the gingival crevice and vice versa. Remember that junctional epithelium has those wide cellular spaces. That's where the gingival crevicular fluid comes. This is where our PMNs, our neutrophils, first line of defense is coming from, in that gingival crevicular fluid. The dentogingival unit is involved in the attachment of the gingiva to the tooth. We've got our biological width, 1.5 to 2 millimeters. Okay, of the biological width, what does the dentist need to, what is their millimeters they take into consideration for prosthetic treatment? They use the 3 millimeters on a radiograph. So they need a good radiograph with not a lot of vertical distortion, so they can measure where the margins of things are going to be. There must be adequate amount of bone from the finish line to the crown of the crest of the bone in order to not invade that biological width. If the biological width is not adequate, inflammation is going to occur. And again, what is the hallmark for that biological width on a radiograph?
CJ?
2 millimeters.
3 millimeters, thank you. Read my mind. 3 millimeters. It's 1.5 to 2 millimeters by the textbook, but on a radiograph, you're looking at 3 millimeters. Okay. We did it. So there wasn't a lot of new information here, but there's information that you need to revisit to learn. So Michaela's going to get me new, she's going to fix my dates, tell me what dates I need to put for the quizzes. Next week we meet at 8 a.m.
Misty,
Yeah.
are the quizzes multiple attempts or just once?
No, it's one attempt, and it's there on the directions that you have one attempt. But it's open book.
Okay, thank you.
And they're usually 10 questions. I think I have a 20, if it's too, it depends on the amount of information. You've got 20 minutes. If it's got 2 chapters, you've got more time. So I want you to, even if you don't have time to visit the book before lecture, at least look at the pictures to know what we're talking about. At least look at the pictures before lecture. Listen to the lecture. Read the book, go through the text, take your quiz, okay, and you should be good. Any questions? Okay.
Miss D, about the quizzes, it says only one attempt?
No, it says only one attempt.
Yes.
Okay, well, I'm an email away. Please, ladies and gentlemen, if I don't email you back, please email me again. I would like somebody to volunteer to be a so-called class leader. No, I don't need that. I was going to say a go-between. I'm going to give you my cell phone number. And you'll need this for clinic more than anything. If you're going to be stuck in traffic or with weather or something comes up, you can let me know. Let me give you my cell phone number. It's 703 939 4937. 703 939 4937. If you text me, please identify who you are. I get text messages every year saying I'm stuck in traffic. I'm sorry, I'll be there as soon as I can. And it's like, that's nice. Who are you? So just identify yourself, okay? So I would like one person's cell phone number. You guys can just decide who wants to give me their cell phone number. Just so, like today, I emailed Ari only because she was the first one to come up on my email. So I emailed Ari to say I was having connection problems. So, you know, I might have to get in touch with one of you guys too to pass information. So whoever wouldn't mind being my go-between.
Amanda?
I'm happy to do that. That's fine.
Okay, text me. You text me.
Okay.
Your phone number. Okay, guys, I'm not going to keep you any longer. I will find out what I'll do. I haven't done the shadowing sheet yet because it's a Google Doc that I don't know how to make. But I will include the Thursday afternoons that we are meeting early, because if you live close enough to campus, you might be able to then shadow on a Thursday afternoon and not just Tuesday. It'll give you a little more flexibility. If there are times that you want to come in and somebody hasn't taken a time, say there's 5 students that are allowed to come in and only 3 have signed up. If you want to shadow more than once, feel free to come in as frequently as you want. Okay, but we have to maintain the number to what Ms. O'Brien is wanting. And Amanda, I got your text, so very good. Okay, I thank you all. I will talk to you later. I have sticky notes. Hopefully by Tuesday when we come back in business, I will have a lot of this taken care of. So Michaela, you're getting me quiz dates. I'm going to work on navigate links. I've got my quiz. I'm going to check on OHE dates. I do have navigate links on another sticky note. My shadowing one. I got sticky notes all over the place. Thank you guys. We're out of here.
Thank you.
Thank you. Bye.
Thank you.